This is Unit 2 Group Health Plans. By the end of this unit, I hope that you can understand what health plans are, understand how they evolved, and work through the tax advantage and reimbursement system built in the Section 125 cafeteria plans. I also hope that you'll have a basic understanding of CDHP plans, even for your own benefit as you move forward into the workforce. So I want to take a quick look at some of the pros and cons as to why employees want or offer healthcare coverage. So employer-sponsored healthcare coverage is pretty common. Around 70% of private sector employers use some form of employer-sponsored healthcare program. So why is it advantageous from an employee's perspective? Well, when people get sick, they'll seek treatment. So that's a good reason for both an employer and employee to have healthcare coverage. But from an employer perspective, it's really a good retention and recruitment tool. And I would say, 1980s healthcare might have somewhat still been optional, but in today's society, it's almost a required benefit. I mean, most employees will not take a job without offering healthcare coverage unless they're already connected to a plan, a spouse or a partner that has healthcare coverage. Let's take a look at some of the average premium cost that an employer incurs for healthcare coverage. So the numbers in white are from 2015, and that's what's reflected in the class notes. If you look at the numbers in orange or peach, those are the numbers from 2019. 2020 data isn't available until later October of 2020. So this is the most current data that we have. And as you can see, the cost per employee has gone up significantly no matter how you slice it, whether that's an individual coverage, a family coverage, even looking at union workers, we've seen significant increase in premium costs there. Since the 1980s, many plans have extended coverage to unmarried, opposite sex, or same-sex partners. Of course, as the laws have progressed over the last, I'd say even 10 years, we're going to see those numbers go up. But looking at 2015 data, that was about 30, 35, 40% of unmarried same-sex partners or opposite-sex partners were covered under their employers' healthcare plans, and we started to see that go up just slightly, not significantly, but definitely slightly. And again, I think we'll continue to see that rise, particularly in this upcoming year. So according to a survey put out by the Kaiser Foundation, we've seen a rise in healthcare insurance rose around 5% this year, and worker wages only rose about 3.4%, and inflation rose 2%. So it prompted them to run this data to see how deductibles, family premium, overall inflation, and worker earnings are really comparing to each other. And as you can see, deductibles have risen significantly in comparison to the other three. So that just further emphasizes how much of what type of healthcare crisis we're really in, and that we're really starting to see it in the deductible and what the employees are having to bear the burden of. And again, this is another policy reason why some employers have moved to self-insured models. This is a breakdown of premium coverage, and if I recall, this is also 2015 data, but there wasn't a big significant change between 2015 and 2019 in this data, so I left it where it was. We see that employee contributions vary, and in some places, some companies, some states offer their healthcare coverage with the zero contribution on the employee's part. Now, that's only for like the single employee. If the employee has family coverage, then they just deduct the difference between the single and the family coverage is what they would contribute for the employee's healthcare coverage. So, for example, in the state of North Carolina, as a state employee, our 70-30 plan, which means that the insurance company pays 70% and I've got a 30% co-insurance, that plan fully covers a state employee. But if I add my family to that coverage, then the state, pays a portion of that 70/30, and if I want to upgrade to the 80/20, then I just get that credited, that amount credited towards whatever plan I select. One thing to note, if we take a look here, the overall employee contributed 22% of the costs, with union workers contributing a heck of a lot smaller number, 22 to 13%. But what's really interesting is those who are the lowest paid on average are contributing more to their healthcare insurance, which I'm not exactly sure why that is, other than the type of employer that is probably fitting that lowest paid just isn't the type of employer that's going to pay a whole lot more for their employees' health insurance. So that's an interesting piece to note. I keep referencing self-funded versus fully insured models. And we covered self-funded a little bit when we talked about stop loss insurance, but I wanted to compare the two because it is a merging issue in employee benefits. So when we look at the traditional insured plan, you select a health insurance company, Blue Cross Blue Shield. You're subject to state regulation, and there's a premium. The employer pays a portion of that premium. The employee pays a portion of that premium. And in turn, you don't have the administration and the administrative oversight to worry about as an employer. You just kind of transfer that to another company or to another entity. Very basic risk management stuff. As a self-funded plan, the employer is now holding the risk, with the exception of having a stop loss insurance carrier to take on some of that risk. But the employer owns the risk, meaning they also own the administrative and oversight and cost control mechanisms. Because it's a self-funded plan, though, it falls under the ERISA guidelines, and so it is now federally regulated versus state regulated. And then as far as funding, we call it unbundled fees, but this is where, the employees are paying into these paying into the self-funded account, the rectangle box that I showed in the previous videos, as well as some administrative fees. So the funding is a little bit different. Of course, the risk is significantly different. And I want to take a look at this video.
So funded, hey, full insurance.
Thought you find that to be a slightly funny interpretation of self-funded versus fully insured. So moving on, let's take a look at healthcare coverage and costs and really what's happened over the last almost 40 years. So while it's highly demanded coverage, healthcare coverage, it's also one of the most expensive employee benefits offerings. You'd think over time, if healthcare was more accessible, then your costs wouldn't be as high. That people would access healthcare sooner in their careers. But there are a lot of different things that go into play. One, we've got longer life expectancies. You've got an aging baby boomer population, medical advances, which I would say are probably the most significant contributor to some of our healthcare costs. And then really the tendency to treat death as unnatural and to the point before, spend a lot of money on these medical advances to slow down the progression of disease. And so what we've seen over the last almost 40 years since 1984 is that costs have increased more than 450% because of these reasons. So now we're going to walk through the chronological summary of medical plans and how they have evolved over time and how we've gone back and forth between whether the employee should own some responsibility in these plans versus the employer maintaining like oversight, somewhat of a protective measure over employees. And so when we look at these plans, I found a couple of different demonstrations of how to think about these plans, and one of them is a garden. And what I realized in the last video that I showed you is that the audio isn't working. So please pause this video and watch the healthcare garden video, and then come back to this video and we'll continue the conversation about healthcare benefits. All right. So before we get to the garden, we have to talk about some of the indemnity plans that really started healthcare coverage from the 60s and 70s. They were also referred to as traditional or fee-for-service plans. And at first, these plans only covered catastrophic expenses, and later they added outpatient, diagnostic, and physician and hospital expenses. So indemnity plans basically pay a percentage of the cost of treatment, pay per service. So they might pay 100% of emergency services and 80% of preventative care services for routine doctor visits, such as like flu, earache, stomach issues, and don't require referrals for any of the specialty care. So as you can see here in this picture, if you need a doctor, you go see if you've met your deductible. And if you haven't met your deductible, you pay the bill and mail in this form to get it to be applied to your deductible. If you have met your deductible, then you pay in, or you fill out this form, and then you get reimbursed a percentage of your bill. Now, the pros of this were that the employee had a lot of choice in where they went, what services they got. But as the employer, if you're just reimbursing expenses, what happens? Well, those costs can kind of get out of control, and you might have one employee that's going to see this really expensive doctor for the same thing that the other employee is seeing a doctor for, and their cost payout is disproportionate. So there really wasn't any control as far as equity was concerned amongst employees. So along comes health maintenance organizations. The concept of this managed care became really popular in the 1980s and 1990s and really replaced most indemnity type plans. Insurance carriers have a role in steering healthcare services and care. And then there was a physician referral that was a requirement, and that a participant had to select a primary care provider, that's that gatekeeper, who's responsible for managing the patient's care. So you had to use an HMO network of providers. So that was your in-network providers. Accessing the HMO and allowing the PCP to be the gatekeeper of the patient care were part of the trade-off that normally made an HMO the least expensive healthcare option. And so these plans are actually still pretty popular in some states like California. But essentially you had a set of in-network providers. And if they were not in-network, they were out of network and not covered. So here we have you need to go to the doctor. But say you need to go see an orthopedic doctor. Well, you would have to go visit your primary care physician first, get a referral to a network orthopedics doctor. That referral would then allow you to go see that orthopedic specialist. And it did allow some significant cost control from an employer perspective or from the employer health carrier perspective. And then along came PPOs. They really came about as a resentment to HMOs because of their strict limitations. You know, in one plan year, you might get to see Dr. Joe. But in the following plan year, Dr. Joe might have decided he didn't want to go with those rates. And so he might now be an out-of-network doctor. So you might have to yo-yo around to different doctors. And what we've learned about primary care physicians and their role in our life is that it's really good to stay consistent and have the same primary care physician over time so that you can build relationship. And it's just overall a good comprehensive care model. So these really became popular around the 2000s. And so participants, what it allows is for participants to go out of network, but they have to incur a higher cost. And really what determines in-network versus out of network were whether or not the provider wanted to accept the rate that the insurance carrier was offering. Now, if the provider didn't, then the PPO network would only reimburse subject to the usual, customary, and reasonable plan rate. They wouldn't necessarily pay a percentage of the higher plan rate. So when we look at an example here you are as a patient and you need to go to an orthopedic surgeon. Well, instead of going to your primary care physician first, now you have the option to go see your primary care physician, or you can just go directly to the specialist as long as they're in network. You could go to an out-of-network specialist, and I'll show you some modeling here in a moment that looks at the different fees associated with going to an out-of-network doctor versus an in-network doctor. All right, a point of service plan is not one that we hear a lot about, but it's essentially a hybrid of an HMO and PPO plan. There's wide variations of POS plans, and then another plan called an EPO plan. And really the most popular of these plans include all of those items that are listed. When we look at an EPO, an exclusive provider organization, it doesn't have the referral component of a PPO. It uses in-network only like an HMO, so there's no out-of-network. So it's a hybrid of the HMO and PPO plan. Sometimes it's really hard to distinguish POS plans from PPO plans. And so for an exam, I don't think I'll necessarily test you on, is this plan a POS plan? So don't get too caught up in it. Just to know kind of as an outlier that POS plans and EPO plans are going to be hybrids of HMO and PPO. See if you follow all those acronyms. All right, let's take a minute to take a look at some definitions to make sure that we're all on the same page of definitions moving forward. So first, let's look at a deductible. What is a deductible? It's the amount paid by a participant during a plan year before the health insurance plan will begin to pay for medical expenses. So if the deductible is $200, the plan will not pay anything until that $200 deductible is met. Not all services are subject to the deductible, like preventative services, so that doesn't count towards the $200 deductible. So know what a deductible is. Coinsurance is a participant's share of costs for healthcare services. So that's calculated in a percentage of the allowed amount of service. So remember earlier when I was talking about 70-30 plans or 80-20 plans, the second number is your coinsurance as the employee. So 20% of an office visit of $200 would be $40. So if the deductible has been met, then that's what you're paying. Copayment is another term that is important to know, and that is a fixed amount that a participant pays for a healthcare service. For example, a specialist might have a copayment of $50. And I don't have my insurance card uploaded, but I did pull up one from Blue Cross Blue Shield so that you can take a look and see like where would you find that information about a copay. And that would be here on that right column. See where it says in-network member responsibility. I usually don't list out-of-network folks on that card. You usually have to look to your plan documents for that. But as you can see here, how much would it cost for a copay to see a primary doctor? $25 here. Specialist, $50. Urgent care, $50. Emergency room, $200. And there's your prescription drug breakdown, which we'll come back to in Unit 3. And then as you see there, for preventative care, there's no copay. So there's copay, and then in addition to your copay, you may have to pay a co-insurance, which would be like maybe for x-rays or some other service. All right, and we've talked about a primary care physician. That's the person that manages an individual's enrollment in an HMO and is usually a general family or internal medicine doctor. Now, what we've seen over the last couple years is a PCP option in a PPO plan that allows an employee to pay a lesser copay by having a listed PCP. So if I have my PCP as Dr. Joe, instead of paying the $25 for a primary care visit, I may only have to pay $10. And I guess that's again to encourage consistency in establishing a relationship with a primary care physician, because the data suggests that having a primary care physician helps lower overall healthcare costs because you're constantly going to see, the same person for your care, which makes a lot of sense. A referral, again, is that pre-authorization to go see someone else. And when we talk about in-network versus out-of-network providers, that's all basically a contractual agreement between the health insurance carrier and the doctors. So whether or not a doctor is in-network or out-of-network really stems on whether or not they agree to that particular pricing. And that gets to be a very complex model that Dr. Huff gets into when he talks about contract pricing and contractual agreements. Preventative care is the type of services such as wellness screenings, blood pressure, cholesterol screenings that are not subject to deductibles, copay, and coinsurance. Again, the data suggests that if an employee is getting these types of wellness services, their overall healthcare costs are going to be lower. Out-of-pocket maximum. The most a member pays for a plan during a plan period over the course of a year. That's the out-of-pocket maximum. So when the out-of-pocket maximum is reached, say it's $1,000, once the employee has paid $1,000, the insurance company pays 100% of everything else. So the maximum never includes the premium dollar, but it is a helpful tool when we start talking about HDHP plans and how do you plan to fill in the gaps. And then usual and customary and reasonable fees we talked about in a previous slide, but it's the amount paid for medical services in a geographical area based on what the providers charge in that area. So for out-of-network services, providers can charge a member the difference between the allowed amount and the UCR. So that's where out-of-network folks start to get really tricky because you could end up having to pay a lot more. All right, so we previously touched on high deductible health plans.